So we'll wait for a few attendees to join, then we'll begin. Thank you for joining, everyone. We'll start in another 2-3 minutes. Thank you. Good evening, everyone. A warm welcome from the Krista team. I am Shinka Arora and I will be the moderator for today's webinar entitled Male Infertility, What You Need to Know. Before I introduce our speaker for the day, I would like to introduce Krista. Krista is the mother and child healthcare brand of Redcliffe Life Sciences. It is a complete online reproductive health platform providing all services for fertility and pregnancy, starting from diagnostic tests, advanced genetic tests, counseling services, and doctor consultations, all easily accessed through Krista's online module. So, without further ado, I would like to introduce our honorable speaker for the evening, Dr. Rajender Singh. Welcome, sir. He is the Chief Advisor for Research at Krista. He has been working in the field of reproductive biology and human molecular biology. He is keen on investigating the molecular mechanisms of infertility. Thank you, sir, for taking out time from your busy schedule and speaking to us. Over to you, sir.
Thank you, Srinka.
So you can start.
Okay. Welcome, everybody. We have been working in male infertility for the last 2 decades. And what I'll be discussing with you is less of science and more of general knowledge that everyone who is fertile or infertile or aspiring to have children should know. So, infertility is typically defined as inability to initiate a pregnancy within a period of 1 year of regular sexual intercourse, that too unprotected, all through. And what does that mean typically is that 1 year doesn't mean uh, with the gaps of months, with the gaps of few days, because you cannot track ovulation, and we do not track ovulation as such unless we are detected to be infertile. So typically, it is not so easy to calculate the time duration that you can tell your doctor that we have been trying for so many years. So you have to be very intelligent with respect to that. Say how long you have been trying, have you been following what is recommended, are there gaps, have you not been living together, husband and wife, for the last say a few days in a month, and maybe few months in an year. So that is very, very important to understand, because once you are diagnosed to be infertile, unknowingly a stress cycle begins in your mind. And yes, it is important to accept once we are diagnosed to be infertile, but what we have to be cautious about is that it should not be a premature definition of infertility for anybody. Because what we have seen in our experience that some patients, they conceive even after 5 to 6 years. But that does not mean that everything had been going all right. There could be some things which were wrong, but at the same time, in certain cases, it has been that the sexual intercourse has not been regular and protected for a period of at least 1 year. Coming to the next, infertility is growing. We have about 27.5 million infertile couples living in our country, and this has been increasing. The fertility parameters, the semen parameters have been declining. To understand that, what we did is we collected semen profile data for Indian fertile controls and infertile individuals over a period of last 40 years. And we performed a meta-analysis on that. As you can see in this slide, I do not have a pointer for this, sorry about that, but I think it's easy to follow. If you see in this slide, sperm count per million was 87 in the year 1979, and over a period of last about 40 years, it has dropped to about 64 million per ml. That means there has been a decline in the male parameters, in the semen parameters, and obviously that decline is somewhere related to infertility, somewhere to the growth of infertility, and it would definitely affect fertility parameters even in normal individuals. Next, Anika. These are some of the excerpts from the newspapers. Please scroll through these 3, 4 slides. I'll not spend time on them. These are simply the clips from the newspapers you may have seen, you may have read some of them, you may have read some of them very recently as well. But all of them, what do they tell is that basically it is a global warning that we have to take it seriously, the decline in the semen parameters that is taking a toll on fertility. And infertility is growing. We can see that from the number of infertility centers that have come up across the world and in our country. I remember a few years back, about 15 to 20 years back, infertility clinics were, high-end specialties seen in big cities, or you can say they were not very common. They were not a common sight in the city. But now you can see infertility clinics growing all around. You can find them in small cities or maybe in towns as well. Basically, what does that indicate? That indicates that infertility is growing. In general, about 15 to 20% of the couples, they face some infertility issue in their lifetime. And out of this percentage, males contribute to roughly 40% of the times of the cases. Females contribute another 40%, and 20% of the couples, they have mixed factors, something on the male side, something on the female side, both coming together and complicating the situation. Sonika, can you go next? These are the semen parameters that are defined by the World Health Organization for calling somebody technically fertile, theoretically fertile. The volume of the ejaculate has to be 1.5 ml or more. The pH has to be 7.2. Sperm count has to be more than 15 million per ml. Earlier it was higher, but now it has been reduced to 15 million per ml. The total sperm count has to be about 40 million or above. The vitality has to be more than 58%, motility has to be more than 40%, and progressive motility has to be more than 32%. Liquefaction time, I'll come to this. This has to be less than 60 minutes. Sperm morphology has to be more than 4%. The patients, or even those who are not patients, who are interested in understanding these things, must take a note of these things, that once you get your semen profile checked in a diagnostic laboratory, it is important for you to understand what is wrong there. It is not simply a solution to visit the doctor and seek advice, because you also need to educate yourself so that you can take informed decisions, you can have a discussion with the doctor, and ultimately you can also plan along with doctor how to manage your infertility. So here you have to take a note that the number of sperm has to be more than 15 million. And liquefaction time, these are some of the things. For example, you cannot check sperm count at home, you cannot check sperm motility at home, but yes, out of these parameters one can always check liquefaction time at home, because liquefaction time is also a problem in some patients. So as you know, semen is ejaculated as a coagulum of the proteins which have a sperm embedded in it, and upon ejaculation it starts liquefying. The proteins, they start degrading and it starts liquefying within about 5 to 7 minutes, and it should be completely liquefied in about 15 to 30 minutes, or maybe maximum 60 minutes. That is why it is said that liquefaction time has to be less than 60 minutes. So in case it does not liquefy even up to 60 minutes or maybe 2 hours, then you can understand that this is something abnormal, and there are specific treatments with the problem of liquefaction of semen. So in that case, you can self-diagnose at least one problem in case you suffer from that. Next, Anika. You must also understand the definition of infertility, because once you go to the doctor, they use some technical terms, or once you get a report from a diagnostic laboratory, you see some technical terms. So as I just mentioned, it is important to educate yourself, because That way, you can discuss it better and manage it better. So these are the types of infertility. Technically, we call them oligozoospermia. Oligo means less, means when less number of sperm are produced than adequate. There is azoospermia. Azo means there is no sperm. No sperm is produced in the ejaculate. There is teratozoospermia, that is abnormal sperm morphology, means the sperm is not abnormal in its size, shape, texture, motility, and all the physical parameters. So something or the other is wrong with the structure of the sperm. And last, you have asthenozoospermia, that means slow sperm. They have reduced motility. It is very important to understand each of them because the treatment also differs accordingly. And your doctor would advise you a treatment depending upon the type of abnormality that you saw. So it is important for you to understand a little bit about this. I would just like to quote something here. Very recently, I met several patients of infertility in the United States of America in a infertility clinic. So those patients, they had, a lot of knowledge about sperm parameters, WHO parameters, the definition of infertility, what kind of infertility they had faced, and they discuss it actively. Somehow in our environment, it is a bit less. One of the reasons behind that is that we do not do our own homework. We must do our homework. We must try to understand the basic concepts. Yes, the treatment is to be taken care by the doctor, but we must educate ourselves with respect to understanding infertility. And that is why we thought to put some of the things together because they may help you in understanding the type of infertility one is suffering from. Sarinka, next. And the first IVF child, as you know, IVF is in vitro fertilization. Today, we also call these as assisted reproductive technologies, was born in 1978. And that was a miracle, no doubt. Somebody who is infertile could father a child. That is miraculous. And even today, we do that so regularly that more than 10 million children have taken birth using IVF. But we must remember that it is not a simple solution, and we should not always jump to the tertiary care of treatment. There are steps, we must go through them. It is possible that our problem does not need us to go to the tertiary or quaternary level because we can manage it using some other methods. Why it is important, I'll just show you in the next slide, because in case you go for assisted reproduction, it has been recently discovered that children born by assisted reproduction are not always normal. I do not mean to say that they are always abnormal, but some of the abnormalities have been seen in a higher percentage of children born by assisted reproduction. Basically, you can see that there is backward-Widerman syndrome reported to be high in children born by IVF, Angelman syndrome, Prader-Willi syndrome, and Silver-Russell syndrome. Some of these syndromes, they are developmental abnormalities, have been noted more often in children born by assisted reproduction. Therefore, by jumping to IVF or ART right away, without considering other steps or without considering a natural pregnancy, the possibility of a natural conception, we are also taking some risk. It is not entirely risk-free because there are issues that some patients cannot afford IVF, but many others they can. But even for them, it should not be so simple that, oh yes, I can afford, so I should right away jump to IVF. Why should I think about anything else? Why should I think about a natural conception? No, the reasons are not so simple. The logic is not so simple to conclude and jump over to ART. You must consider everything and you should make an informed decision in consultation with your diagnostic, with Krista, or with your doctors. Next, please. So for understanding infertility, let's first understand where spermatogenesis takes place how sperm are produced. Sperm are produced in the testicular compartment. As you can see here on the right hand side, this is how the testicles look like. They hang from the abdomen using certain cords, and these cords, along with the hanging cords, also consist of blood supply and the spermatic cord. Next, please. The testicles basically they hang in a pouch of skin, what we call as scrotum, and this is a naturally designed way of having optimum spermatogenesis. Because the testicles they hang in the pouch, they remain away from our body. They are not supposed to touch our body because they have to regulate the temperature. So accordingly, the length of the pouch, the tightness of the pouch, that varies according to the temperature, outside temperature, the temperature of the body, so that the testicles are maintained at a temperature lower than the body temperature. They are typically at 2 to 3 degree lower than body temperature. So human body temperature is 37 degrees Celsius. So the spermatogenesis in your body is taking place at 34 to 35 degrees Celsius, 2 to 3 degrees lesser than your body temperature. Why I am emphasizing on that? Because it is very important to understand for anybody that it is not just that you can heat testicles, you can wear anything, and you need not care about it. Nature and the biological mechanisms they will take care of itself. No, that doesn't happen. In case we heat testicles, we are definitely going to damage spermatogenesis. Next, please. Next again. So I have listed a few types of infertility here. One is cryptorchidism. So in this case, what happens, as I just discussed, that testicles they hang in a pouch called scrotum. In these cases, those who are called cryptorchid, the testicular descent phase. The testes they do not make their way to the scrotum, and they hang at various places. They could be in the abdomen, they could be in the inguinal canal, or they could be high up in scrotum. So from the previous slide, I'm sure you can understand that in case they are high up in the scrotum, in case they are in inguinal canal, or they are in abdomen, they are very likely at the temperature of the body at which spermatogenesis cannot take place. It is not reduced, it cannot take place. So we have seen creating these models in the animals. So in rats, what we do is we push the testicles back or we tie them with abdomen, and that completely stops spermatogenesis. So it is not that the variation of 2 to 3 degrees would affect its level or its intensity. It will altogether stop. It will altogether blow within a matter of days. So it is important to understand that those who are cryptorchid, yes, they can get better, but that has to be done as early as possible. Next, please. The other parameter that one should understand, and most often one can self-diagnose, is testicular size. So the testicles, they start developing from very small size of about 1 cc, and they go all the way up to 25 cc. So the normal variation, the normal range in humans is something like 18 to 25 cc. So that is the testicular volume. If you have a good sense of measuring the volume, you can feel the testicles yourself and you can judge its approximate volume. So each testicle has to be roughly about 4 into 3 into 2 centimeters. So that makes it something around 24 cc. So you can easily perform this scan at home yourself, and in case you find that there is some issue with your testicular size, that could likely be the cause of infertility in your particular case. So this can be performed, but yes, the size I'm talking about is the adult size. That is something between 18 to 25 cc. Next, please. Another not very common cause, but in certain cases, this causes infertility, what we call as testicular torsion. So in this case, one testicle, because of injury that gets twisted, and though nothing happens to the testicle because of twisting, spermatogenesis can still take place. But the problem is that it restricts blood supply, and also sometimes it gives a torsion to the spermatic cord. So basically, in case blood supply is blocked, spermatogenesis cannot be optimal, and at the same time, if spermatic cord is twisted, it cannot transport sperm from testicles to the ejaculate. So that makes a problem. This generally does not happen in adults unless there is any injury, but in case there is some injury, testicular torsion happens, this needs immediate attention and is generally a medical emergency. This sometimes happens in early adulthood, around puberty, sometime between the years of 12 to 18, you can say in the adolescent boys. But in that case, it should not be handled at home. One should not try to reverse it. One should not try to relieve the pain by doing something to the testicles. It can permanently damage them. You have to take it very seriously. Nothing to be done at home, nothing to be done by anybody else who claims that I can treat these things unless he is a medical surgeon expert, preferably a urologist. And it is associated with generally associated with pain and is an emergency, medical emergency that needs immediate attention. We should not ignore it. Next, please. The other is hydrocele. You may have heard about it. This is a very rare cause of infertility because if you see, basically hydrocele is the development of a cavity which gets filled with fluid between the layers that cover testicles. So there are two layers, tunica albuginea and tunica vaginalis. So they uh, give away from each other, and the gap between the two that gets filled with certain fluids. And because this is not a normal situation, so this fluid that invites inflammation, and because of inflammation the temperature rises and there are many molecular changes. Ultimately they affect spermatogenesis. So in case of young born children, in case there is hydrocele, it gets repaired automatically. It generally does not need attention. But in case of adults and adolescent boys, this needs attention. This generally does not self-heal and needs medical attention immediately. Because in case this is left untreated for long, this can even permanently damage the testicular tissue, making you permanently infertile. So for that, in case this is in adults, one should immediately consult a doctor for the management of hydrocele. Next, please. Yet another is varicocele. This is relatively more common than others. What happens in varicocele is, as we have understood in the previous slides, the testicles they hang in the pouch with the hanging cords and with the veins that supply blood along with spermatic cord. So sometimes these veins they get swollen because of certain problems, because of certain infections, because of what we generally call in layman language the thickness of blood, because of certain deficiency of vitamins, because of many vitamins deficient in our system. The corpuscular size, that is the size of the blood cells, that increases and ultimately that blocks the veins supplying blood to the testicles. Because of this, as I mentioned in the previous slide as well, because of restricted blood supply, there is a severe effect on spermatogenesis, and this can turn one infertile. Generally, this is on the left side, but it can be on the both sides as well. So varicocele can very much be treated, and sometimes, if you are quite intelligent, you can also diagnose it at home. At least you can get a hint that yes, I may have varicocele, so that you can discuss it with doctor in an informed way. So for this, you have to just take the skin of the scrotum in your hand, and this has to be right above the testicles beneath the penis. So there you take it in your hand and you feel it with the two sliding fingers. You would see that there are certain thread-like structures or certain vein-like structures between your fingers. Don't worry about them. You can just slide it over each other and you would feel if there is anything like a kink, if there is something which is swollen, if there is something which looks like a cyst. So those things you may be able to diagnose yourself at home. But take care that I'm talking about a light diagnosis. You do not have to actually twist or turn or press or massage anything. So for that, you can compare the left side with the right side. So sometime, because it is on the left side, you can find a difference. You can observe a difference between the left and the right side. So that may give you the right diagnosis that probably I have varicocele. But yes, ultimately this should be subjected to a proper diagnosis by an andrologist or urologist in a clinic. But varicocele is very much manageable. This is a treatable cause of infertility, and basically, you can say one way getting diagnosed infertile with varicocele is not a bad news at all. Next, please. I'll come to touch a little bit on diagnostics, and it is not too much of complicated stuff that I'll talk about. It is very simple, but it is also very important to understand how diagnosis in this field works. And you definitely must know about this basic parameter that is Y chromosome. So, as you know, the males they have Y chromosome along with an X chromosome, and females have two X chromosomes. So that is how we genetically differ from females, and this Y chromosome is what makes us males. Next, please. We always receive Y chromosome from our father. So this follows patriarchal lineage. That means a Y is transferred from male to male only. It does not enter female lineage, of course, and we do not give our X to our sons. We always give our X to our daughters only, and we give Y to our sons. So this follows a patriarchal lineage. And I forgot to tell you in the previous slide, Y chromosome has one gene on it that you must remember, that is SRY gene, sex determining region of Y chromosome. Basically, yes, here it is. If you can see SRY label on this tiny chromosome, this is a very small chromosome. This SRY gene is basically what makes males males. Otherwise, in case you lose S or Y, even if you have the whole of Y chromosome, you won't be a male. So for being a male, Y chromosome is necessary, but in first hand, it is SRY that is necessary. Sarinka, can you please jump? Yeah, next. Yes. Uh, Y chromosome undergoes a number of duplications and deletions, and it has been seen. You may not need to focus on this slide. Don't worry about what are these white patches on over there, but just listen to what I'm saying. So Y-deletion undergoes a number of deletions, duplications, recombination. Somehow, the nature of this chromosome is that it undergoes frequent changes. And because of these frequent changes, sometimes there are deletions. The genetic material, the DNA on the Y chromosome that gets deleted. So that gets out of the system. And because of that, we face problem in spermatogenesis. But this is very much doable in a diagnostic setting, in a diagnostic laboratory. Y deletion analysis can be performed easily, and I suggest that it must be performed before undertaking any management of infertility in an individual. And we have developed a technology for the analysis of all Y deletions in one go. We are very soon transferring it to Redcliffe and Krista, and they will be doing it for the patients. and they may even be supplying it to others. But the beauty is that it can help you a lot in the management of infertility in the best possible, economical, and fastest way. Next, please. So here I have shown a scheme how Y-deletion can help. You must have understood by now, as I mentioned, a Y chromosome and SRY are must for you to make a male. Not only a male, but also to make you a fertile male who can actually produce sperm. So for that reason, it becomes important to first check whether you have a Y chromosome, and if you have, whether that Y chromosome is intact or it is fragmented, it is broken, it is deleted, how much of it is left. Is it 80%, it is just 10%, or it is 100%? So that has to be checked. And accordingly, in case somebody is oligozoospermic, if you see on the left hand side, that means somebody is producing less number of sperm. So that makes one infertile. And if you find the individual has Y-deletions, so this person is not suitable for treatment using vitamins and hormones because the Y chromosome is not intact. Y chromosome is broken somewhere. So such a person may end up wasting time in case he seeks treatment with vitamins and antioxidants. Because by just giving vitamins, they will not make sperm. They will ultimately act via Y chromosome. And Y chromosome is already broken. So in such cases, we keep on taking and we do not see any results. The patient ultimately ends up wasting time, maybe 6 months to 1 year, or maybe even more. And as I previously mentioned, once you discover that you are infertile, moreover, when you discover that your fertility treatment is somehow not working, you make a vicious cycle of stress with your brain. You perceive it at the level of brain, then ultimately the changes at the level of brain reflect in your hormones, and the hormones they get disturbed, ultimately making you further prone to infertility. Even if you had few sperm in your ejaculate, you are very likely to lose them because your stress level is rising. So that is why it becomes very important. It is so important that you do not take up it to the level of brain and making a vicious cycle that no, I cannot get better using any of these treatments. So before that, we must perform Y-deletion analysis, and we discover in case such a person has broken Y chromosome, you can right away go for IVF. There is no issue because it is not possible to make things better. You are ultimately even going to lose the sperm count that you may have. On the other hand, somebody presenting with oligozoospermia, please again keep on the left side. I am saying oligozoospermic minus. So here you find after Y-deletion analysis that your Y chromosome is okay. It is perfect. No issues with that. That means the inner machinery that is fine. Something has gone wrong somewhere else. Could be vitamins, could be nutrients, could be stress, could be working environment, could be anything else. So there, yes, because you have a good Y chromosome, you are very much eligible and very likely to respond to the treatments using hormones and antioxidant or vitamins. And in such a case, after initiating the treatment, you can look for a natural pregnancy for say next 6 to 12 months. Very likely you will respond, and as I mentioned in the very first slide, natural pregnancy is far more better than assisted pregnancy. Remember that, don't forget that. So in case you can somehow go for a natural pregnancy, you must try for that. Yes, you can still consult a doctor, you can still consult Krishna, you can still consult somebody doing Y-deletion analysis, but you must try for a natural pregnancy there in case you have your Y chromosome intact and you are producing at least few sperm. I have treated many patients that way, those who were producing few sperm, and advised them to go for something, and they ended up having a successful natural pregnancy. But we should not ignore that. And in case we right away jump to the conclusion that, oh yeah, I have to go for IVF, then obviously there is no one who can help you. That is why it is important to understand yourself. What is infertility? What type of infertility do you have? Do you have only infertility, or your Y chromosome is okay, or you have both? You have infertility and your Y chromosome is also not good. So these are the things you should understand. And ultimately, again in the same line, in case you do not find any benefit after 6 to 12 months, IVF is not going anywhere. You already have some sperm produced. You can go for IVF, and you can even store some sperm in advance so that in case something happens with time, you can use your cryopreserved sperm. And now let's move on to the right hand side. On the right hand side, you see a previous place. Yeah. On the right hand side, you see there is azoospermic case. So azoospermic means no production of sperm. Sorry, no sperm in the ejaculate, not no production. There could still be production. So in many azoospermic cases, there are problems with the spermatic cord or the ejaculatory duct, or there are other issues which are beyond testis. So in those cases, sperm are produced, but they are not ejaculated. So they also become azoospermic. We call them obstructive azoospermia. Obstructive, something is obstructed somewhere because of which sperm are not able to come out. So that is obstructive azoospermia. In case you get diagnosed with infertility with obstructive azoospermia, this is a good news. That means everything is going good in the testicular compartment and you have no issues with spermatogenesis. Probably there is some blockage somewhere which can be treated by surgery. So it's important to diagnose. But suppose you find that you are azoospermic and this is not obstructive. This simply means you are not producing any sperm at all. In your testis, there is hardly any production of sperm. So there too, Y deletion analysis, Y chromosome analysis becomes very, very important. And what we do is we perform Y analysis using the markers I just described. And if you find that there is a deletion in, right now I am on the right hand side block, uh, somewhere near AZFA or AZFB deletion. So in case you find that there is AZFA or B deletion, that means there is no chance of finding sperm in the testis. That also means there is no point in opening up the testes, there is no point in performing testicular sperm extraction, and this person is a case for IVF. So such a person should right away go for IVF. Coming to the second column in right hand side block, in case one is diagnosed with AZFC deletion, I hope you can follow AZFC deletion, that is middle. There there are chances that some sperm, few sperm may still be present in your testes, and the doctor should perform testicular sperm extraction. So in that case, it doesn't matter even if the doctor has to take one testicle and open it all together. Anyway, it is meant only for that. There is no fun in having them hanged around in case they cannot produce sperm for us. So in that case, you don't mind, go ahead with the testicular sperm extraction. If you find sperm there, you can right away go for ICSI. Remember, despite being azoospermic, after performing Y-deletion analysis, you may find some sperm, some of your own sperm, to perform ICSI and have your own child. In case still you are unfortunate not to find any sperm in the testes, you can go for IVF. And in case there is azoospermia, coming to the right hand side, the extreme end, in case there is azoospermia, there is no deletion, you have completely intact Y chromosome, you are still a good case for testicular sperm extraction, and you should follow the same path of trying to find sperm in testis. If you do, go for ICSI. If you don't, go for IVF using donors. Next, Rinka. The Y-deletion screening that I just mentioned, it is not only for infertile individuals. In case one is diagnosed with infertility, you may have your younger brother, you may have other boys in the family, you may have your elder siblings, who are suffering from infertility, or you may have grown children who are above the age of 20. So there you can still perform a Y-deletion analysis and calculate their risk of infertility in advance. Why? Because at least one member in the family has been diagnosed with male infertility. So why don't we perform a screen on the others in advance? As soon as they complete their puberty, they step into early adulthood. That time we can perform a scan of Y-deletion analysis and figure out their infertility risk. Suppose somebody has a very high risk, something like 40-50%. For those individuals, we can ask for sperm cryopreservation well in advance. Or we can even think of their family planning, their marriage, their children well in time. Somebody who is oligospermic, say by the age of 25, gets married by the age of 28 or 30, doesn't want to have children for another 2 to 3 years because he has to take world tour. So in that case, he is risking himself further. You may find that after having all that hunky-dory time for the last 3-4 years, you discover the infertility at your doorstep, and now you keep on struggling with that for the next maybe a decade. So rather than undergoing that, why don't we perform a screen well in advance? We undergo so many tests, we undergo immunization, we get our children immunized with so many vaccines, and we undergo certain other tests as soon as we grow up. So why don't we perform another scan for fertility? I think this should, I rather encourage whenever I give any lecture on that, I always encourage people to go for a fertility screening test early in life. It is important. It can save you not only a fortune but also a good life. Can you please go to next? I have just shortlisted the two benefits that I would like to discuss and present it to you. Once you present to a diagnostic center for Y deletions for the management of infertility, please keep in mind, do not just visit an IVF where all these scans are not performed, they are not discussed with you. They must be discussed with you, your diagnostics should be discussed with you, and it must include a Y chromosome workup. Because as I discussed in the previous slide, I just told you how you can select a particular path. In case deletion is there, you go for this. If in case deletion is not there, you go for this. And in case there is a deletion, there is this situation, then you go for something else. So by doing that, what are we doing? We are saving time and money. So I have just listed here that at present, infertility treatment ranges from something like 15 to 16 months, 60 months. That means from 1 year to all the way up to 5 years. By doing a Y deletion analysis or performing these scans, we can reduce it 2 to 12 months. We can shorten it very much. And in case you are able to shorten infertility treatment, the people get better, they gain confidence, and they can even think of managing their next child in a better way. And the other advantage is that we can reduce the cost. At present, IVF treatment, it's somewhere between 2 to 5 lakhs, which is affordable to many, but not to everyone. And even if it is affordable, as I just mentioned, it is not the only way. You should not jump to IVF. So with Y-deletion analysis, we can reduce the cost to just 20,000 to 2 lakh. What do I mean by that is, in case we are able to diagnose and recommend a particular treatment to you, you can right away go ahead with that. You can right away go for IVF, or you can go for natural conception, and that saves you time and money both. Next, please. This is a part of the same thing. So in case you see any of the abnormalities I mentioned above, in case you see one is infertile, in case you see genitals have a problem, in case you see that there is a child born or there is a young boy in the family who has some developmental issue with respect to the external genitals, you should always go for genetic testing. Like in this case, you see abnormal external genitalia which are not differentiated. It has a bifid scrotum, a small penis, and you do not see the differentiation in either male or female organs. Genetic testing in this individual identified a mutation in SRD5A2 gene, and further management will depend upon that. Rather than waiting him to get into adulthood with the problem, it should be managed early on. Next, please. These are our experiences, these are our patients. In some other cases, you see that everything is there. Y chromosome is there, it is intact. Androgens are produced, testicles produce testosterone, but they fail to work. The androgen doesn't work because there is a problem with the androgen receptor. The gene, the protein where androgens work, it is defective. And genetic testing in this individual identified a mutation in androgen receptor. You can see there is improper differentiation of the external genitalia. He has a fused scrotum, micropenis, and gynecomastia, that is development of breasts in case of males, scanty pubic hair, and you can see lean body mass. There is hardly any muscle mass there. So these people, they suffer from androgen insensitivity. Means androgens like testosterone are produced, but they do not work. Next, please. This is a case of complete androgen insensitivity syndrome, which we identified. The whole family was there. We identified it in a small child. So these are basically males. They are 46XY. And unfortunately, the androgens, they do not work because there is a problem with the androgen receptor. And because of this, they take the default developmental route to a female phenotype. And in these individuals, genetic testing can help in the identification of mutations. I am talking about this particular patient. She visited me so many times, and ultimately, we managed her development. We managed surgical repair everywhere, wherever it was possible, and is living a normal life. But this needs advanced screening to understand infertility. Next, please. This is a child from this same family I just described. There are external female genitals, but they are 46XY male individuals having testicles inside the abdomen. As you can see on the left side lower panel, these are the testicles inside the body, and they need to be removed. Very recently, there was a news from Kolkata in a newspaper, maybe in many newspapers, that there is a woman found having testicles inside the abdomen. This is not surprising. This is very common. This is very well known. Not very common, you can say. This is very well known. They are relatively less, yes, but these are the cases where genetic testing is important. We need to identify what is causing the problem, and ultimately we need to manage them according to the genetic diagnosis. So in case these individuals, they do not undergo genetic testing, they do not identify the problem, they have testes sitting in the abdomen. As you can very easily understand, testes are not supposed to sit inside the abdomen. So something will go wrong. And what happens is, by the age of 30 to 40 years, these people develop testicular cancer because the testes are at a higher temperature than what they should be at. And that is why the management early on is required, and for that, a genetic testing is must. Next, please. This is another individual, as I just mentioned, the benefit of genetic testing. This is an individual who had 46XX chromosome complement. So he was not a 46XY, but was still a male. So he had 46XX, and somehow the SRY gene that migrated to the X chromosome. And the individual has SRY gene but does not have a Y chromosome. Remember it. The other parts of the Y chromosome, they are required for spermatogenesis. But to make male a male, only SRY is required. That is why this person, despite being 46XX, is a male. He has got SRY somehow on his X chromosome, but he cannot produce sperm because he does not have the other part of Y chromosome which makes spermatogenesis possible. Next, please. This is another case which was 46XX, and we tried to figure out if SRY is there, but we could not find, and we could not explain it. What the reason is for him being a male, we could not explain it, or Y could be fragmented, SRY could be fragmented, but we could not discover it in this patient. And he was still a male. This was published, but that also shows that it is very important to undergo genetic testing, to undergo karyotyping, or a particular gene testing before we take up the management of infertility. Otherwise, these males, I just showed you 46XX SRY plus, 46XX SRY minus. Otherwise, they would wonder, say, I am a completely normal male, but why am I infertile? So here is the answer. This is why you are infertile. This is why you should take a donor sperm. This is why I think that you can never produce sperm. So it is important to understand and discover what kind of infertility you have. Next, please. Go to next. Here are some suggestions. Again, like say, why so much of infertility is around nowadays? Why infertility is increasing? So a major factor behind this is lifestyle. It is even about genetics. It works in combination with genetics, but our lifestyle that matters a lot. Say we use a lot of radiations, we use Wi-Fi, we use mobile, we use many other radiations, and none of these are visible to us. How many radiations are penetrating through your pants? You do not understand that, because we are all surrounded by radiations. Even now we are talking using radiations. So they may have some impact somewhere. Yes, still there are no confirmatory studies that Wi-Fi and mobile radiations they affect fertility, but they may do. We have yet to quantify how much of effect they have, but they may have. And in case one uses tight garments, you are habitual of wearing very tight garments, you wear tight undergarments, so that basically pushes the testicles close to the body, and you do not have any airflow. The local temperature rises, and because of temperature, spermatogenesis falls. Remember, temperature, particularly testicular heating, has so much effect on spermatogenesis that this has also been proposed and used as a method of contraception. You can understand from that how strong impact temperature can have on spermatogenesis. The other is excessive exercise. No, please go back. The other is excessive exercise. Some people are fond of exercise, no doubt. It's good, it's better, but it has to be regulated. You do not have to do excessive exercise. It's bad. You do not have to work continuously. You have to take breaks. You have to respect the biological clock. It is not that simple that, oh, I work over the night, I sleep during the day. This is not what nature uh, has uh, asked you to do, right? So in that case, you basically reverse it. Hmm? You are basically playing around with the biological clock. So that disturbs all the hormones. There are hormones which are synthesized in dark in the night, and they are essential for spermatogenesis. You should not, another parameter is you should not take stress. Stress is a big killer of infertility. Stress could be related to your infertility, or it could be related to anything else. So if you allow stress to penetrate your brain, you are basically allowing it to penetrate your testicles. You should avoid all these sauna baths, heat baths, and all that. There is no need of that. It is better to have fun in the sun, rather than lying in hot water. So remember that if you visit a luxury five-star hotel, do not try to engage in all these things just to celebrate. It is not for you to celebrate anything about heating your testicles. You should not smoke. Smoking takes a heavy toll. It has been reported to be a strong cause of infertility. In case you smoke, it's your testicles. They have a lot of chemicals. I don't remember the exact figure, but they say that some thousands, probably more than 10,000 chemicals are generated during smoking. And obviously, you can imagine what they can do to the testicles. Then drinking also takes a toll on spermatogenesis. It has to be avoided. And sedentary lifestyle. You just cannot afford to eat anything, get fat, lie down, and watch TV, and still ask your testicles to produce good sperm for you. No, that doesn't happen, because in case you gain weight, your weight that deposits on your thighs, on your abdomen, and ultimately that restricts the breathing space for the testicles. Next, please. So this is just an anti-slide to the previous one. So in case you want to have good fertility, switch off your mobile, Wi-Fi, or anything else that you do not use, particularly say at night. Use loose garments, particularly undergarments. Undertake exercise that should be moderate, it should not be heavy. You should take breaks from work. You should respect biological clock. Do not take stress. Do not hit your testicles. Do not smoke. Do not drink. And try to live an active lifestyle. Next, please. I think that's all I have. And in case you learned something out of this, and you are suffering from infertility, I'm sure Radcliffe, Krista, your advisor, and your own knowledge, that will all help you in a new beginning. Thank you very much.
Thank you so much, sir. That was a wonderful presentation on your part. We have some questions for you.
Please.
So I'll tell you the questions one by one. So one question is, if a man is aged 25 years and has erectile dysfunction and low sperm count, what can be suggested for the couple? How can they conceive?
Right. Actually, low sperm count means how much? Can you just tell me any idea? Has he or she written what is the figure?
No, sir, no. Just generally
Okay.
they have
Okay.
asked.
So my suggestion is that, first of all, do not confuse erectile dysfunction with infertility. Basically, when we talk about erectile dysfunction, it is related to sexual pleasure only. It's not related to infertility. Because sperm production is okay, in case even if it is low, something around 15 million or 20 million, it is still okay. One can still gain fertility, one can still conceive. So for such individuals, if the sperm count is above 15 to 20 million, I would advise them to try naturally, because sperm can still be deposited safely, and erectile dysfunction does not impair fertility.
Okay, sir.
And it is treatable. It is treatable. Medicines are available. You can treat erectile dysfunction as well.
Okay, thank you, sir. Mr. Rajendra wants to ask that his sperm analysis shows a sperm count of 22 million, motility is 35%, and normal morphology is 40%. What options
Okay.
are available to allow higher chance of conception?
To this person, I would advise if he can better go for Y-deletion analysis, and after that, I think he will be a good candidate for antioxidant and vitamin therapy. So for with that, and he should ask himself if he has any lifestyle factors that could be affecting his fertility. So take care of them, get Y-deletion checked, and then start antioxidant and vitamin therapy. And I will suggest wait for 6 to 12 months after that. You are not in a bad shape. 20 million is a good count, and about 35 to 36% of motility is also very good. There is hardly any issue, but you have to have patience. You should not right away go for IV.
Okay, sir. Another person, Mr. Ram Babu, he is also asking that he has a sperm count is 48 million, motility is only 10%. So how can he increase his chances of conception? He's 32 years old.
Okay, there are certain medicines which improve motility. If he consults a doctor, or if he comes to say a Krista, we can advise him a doctor. But there are medicines which improves for motility. Hmm? Probably the doctors with Krista also have an array of medicines, not just one. There are many which improve motility, particularly because there is no issue with sperm count here. He just needs to take care of motility. and he can conceive naturally. I think he should specifically consider if there is any factor, lifestyle factor, and then focus on treating the loss of motility. And it can be treated. We have treated patients who had low motility.
So
Fortunately, he
he
has
can
good sperm
directly
count.
contact you or Redcliffe for in case he wants any
Definitely,
suggestion.
definitely,
Okay.
definitely.
Mr. Yusuf wants to ask that his sperm motility is 40 and total sperm count is 88, liquefaction time 45 minutes. How to improve the quality?
I think quality is all right. You said sperm count is what? 80?
Sperm count is 88.
Okay, 88. I do not think there is any issue with the spermatogenesis here. Everything looks good to me. But we must not forget that whenever we are talking about fertility, we are talking about a couple. So we have to also ensure that the other partner, the female partner in this case, is perfectly all right. So these scans, they have to be performed on both the partners. So here, because the male picture looks fine to me, it is possible that there is something wrong on the other side. So in case they have already ruled that out, they should try for natural conception. But if they have not ruled it out, they should first rule out any factor on the other side. It could be sometimes the factor is as simple as anti-sperm antibodies in the females. Hmm. So they have to be primed for that. There are treatments for that.
Okay. Sir, Mr. Venkateshwarlu has a question that he has a severe low sperm count but also a very severe infection. What is the treatment?
I do not know where the infection is, but infection-related infertility is very much manageable. They take some time because in case the infection is somewhere in the accessory glands or it will not be in testicles, I believe. It will be elsewhere, but it is very much manageable. For that, he has to first take the treatment for infection. I hope it is not trichomonas. That is a little tricky to handle. But in case there are other infections, they are very much treatable. He should consult a local doctor for the required antibiotics. And only after that, he should think about fertility after a gap of 3 to 6 months, because semen parameters once compromised, they do not improve overnight. Say he takes antibiotics for 10 to 14 days and after that he expects to be okay after 20 days. That will not be the case. It will take time. It will take time of no less than 6 months to regain sperm count. That is what I advise to him.
Okay, sir, thank you. Mr. Ashok wants to know that he is having a varicocele grade 1 on the left side and main problem is erectile dysfunction and premature ejaculation. What is the solution? The sperm count is 30 million.
Again, just like ED, that is erectile dysfunction, premature ejaculation has nothing to do with fertility. These are two sexual pleasure parameters only. PE and ED for all patients, remember it, they do not relate to your infertility. Do not confuse yourself. In case it is PE, it doesn't matter to infertility, though it is treatable. But sperm count here looks fine to me. Varicocele, in case this has not been a grade 1, it's a good news, it's not a bad news. That means it is mild. And I believe when it is grade 1, it is only on the left side. So he should attend a clinic for the management of varicocele only. And along with that, if he wants to consider treatment for PE, that is up to him. But PE is not complicating his fertility status. It is only varicocele. And he will get better. He should not go for IVF, I believe.
Okay, sir. Thank you. Sir, Kritika has a question. Is there a self-exam for men to know about infertility-related problems?
As I just mentioned that only in rare cases, it's not so easy. Something like a pregnancy test kit, like we have home pregnancy test kit. Such kits for males are under development. So some one or two have shown some promise, but they are yet to come. Where after maybe males will be able to just take the ejaculate, put a drop there, and find out whether they can be called fertile or infertile. But yes, it has yet to come. What all can be diagnosed at present, I mentioned during the presentation, one is varicocele to some extent if you do it intelligently. The second is testicular size. In case one has small testicles, I think it is not difficult to just take a note of 4 into 3 into 2 centimeter. And the third could be ejaculate volume. In case the ejaculate volume is less than 2 ml or 1.5 ml, that means there is something wrong with the male. 1, 2, 3, and apart from that, I think that is pretty much that can be done at home. Testicular size, and yes, liquefaction can also be done, as I mentioned. In case liquefaction is more than 1 minute, that also indicates that you could be infertile. So liquefaction time, varicocele, testicular size, and ejaculate volume. These are the 4 things that can be done at home.
Okay, sir. Thank you. Mr. Vishal here wants to know that for a man who is suffering from congenital absence of vas deferens, what can be done to help the couple to conceive? And what are the causes of CAVD?
Yeah, CAVD is generally caused by mutations in CFTR gene, and this is very much used for diagnosis also. In case mutation is identified in CFTR gene, that could explain CBAVD, but in any case, whether a mutation is identified or not, CBAVD would need extraction of sperm right from epididymis and go for IVF. That is the only solution.
Okay, sir. Sir, Miss Sonia is there. So she wants to know that she has missed her periods, but her pregnancy test is negative. What can she do to conceive?
Mm, uh, this is a little different thing to discuss, because missing period could be indicative of many things. And in that case, she has to first rule out a home pregnancy test, then she has to rule out a blood test. But rather, I would suggest the patient discuss more about infertility. Has she faced similar problems previously, or this is for the first time, or they have been trying for quite some time? Because what happens in many times is that if there is a male factor abnormality, the sperm is good to fertilize. Say it fertilizes the egg and the development starts. So for initial few days, you see missed periods because fertilization has taken place. And the conceptus or the zygote is now trying to attach itself to the uterus. But while the division starts, though division starts beforehand, but sometimes initial divisions are okay, but later divisions are not. And by the time the divisions start, the development starts in the uterus. Because of male factor or female factor, it does not uh, uh, proceed smoothly. And in that case, before the conceptus establishes there, it gets lost. So basically, there is fertilization happening, but there is no pregnancy happening, and you cannot figure out basically how exactly and what exactly is happening there. So in such cases, I think a discussion of detailed history for how long they have been trying, how many times he has faced the same problem, that needs a discussion. And yes, the male partner should be checked for Y chromosome, because in many of such cases, we just blame it on the female, that there is something wrong here, not on the male side. That also needs to be checked.
Okay, sir. And sir, one last question that we have is that can a person's fertility be affected if they have had a vasectomy done reversal for vasectomy and by chemotherapy, if they've undergone chemotherapy anytime?
Yeah. Chemotherapy almost invariably affects fertility. That is why most of the people undergoing chemotherapy, they are advised to collect sperm and cryopreserve them. Yes. And vasectomy, in case somebody has undergone vasectomy and they are now going for reversal of fertility, so it is very likely to succeed, but may fail as well. Because what happens is once we cut the spermatic cord, we try to reattach it to various places. So you do not know up to what length of the duct has got affected. So sometimes the doctor tries to reattach it here, then here, and that is how they try. So it is not always necessary that you will be able to recover, but recovery chances are very high in case of reversal of vasectomy. And chemotherapy, yes, it invariably affects, and sometimes it damages it permanently.
Okay, sir. I think these are all the questions that we have for today. And we'll end our session here. Thank you so much, Dr. Rajendra, and all our guests for being here with us today. And please stay tuned for the upcoming webinars from Krista. Good evening. Thank you very much, sir.
Okay, Sringa, thank you.
Thank you.